One of the greatest challenges in treating psoriasis is maintaining the efficacy of therapies over long periods of time. Currently, we get innumerable studies that show our biologic therapies work really well for the first 12, 16, or 24 weeks. But the real question is, how well are they doing at weeks 48, 96, and so on? Many times we find patients do very well and then lose response. And loss of response can come in many flavors. It could be rapid, whereby the patient loses their control of psoriasis over, say, 6 to 8 weeks, or slow and inexorable, where loss of response is dragged out over 26, 52, longer periods of time. Regardless, there are many mechanisms that might explain this. And one prominent mechanism that we always talk about is immunogenicity. Biologic therapies, by definition, are foreign molecules. And when given to patients, there is the tendency of a patient to, quote unquote, reject the drug as foreign and raise anti-drug antibodies. Anti-drug antibodies have a very simple effect on biologic therapies. They lower the drug level. If you lower the drug level, treatment becomes less and less adequate for that drug level, and patients see a recrudescence of psoriasis. Now, a more recent molecule that was approved for the treatment of moderate to severe psoriasis is Secukinumab. And Secukinumab recently was described with regard to its immunogenicity in a publication. This publication, with the first author, Christian Reich, examined Secukinumab in 6 different clinical trials for psoriasis in phase 3. The patients in these studies were evaluated at 5 different time points, including at baseline, for the presence of anti-drug antibodies with regard to Secukinumab. And what was found over thousands of patients, that immunogenicity was quite rare. In fact, the percentage of patients demonstrating an immunogenic response to Secukinumab was 0.4. And if you specifically looked at the percentage of patients who showed anti-drug antibodies that actually neutralized Secukinumab, blocked its ability to bind to IL-17, in other words, that number was more like 0.1%. So it's safe to say somewhere between 1 in 250 and 1 in 1,000 patients will be, quote unquote, victimized by immunogenicity. Nevertheless, the authors of this paper showed that even in patients showing immunogenicity, loss of response wasn't a consequence. So the upshot is Secukinumab is a low immunogenic molecule, and it is more likely to retain response because of this fact. Now, in the real world, we use Secukinumab quite often, and I personally have used it in scores of patients and do see loss of response over time. Specifically, patients can clear or almost clear in the first 2 to 3 months of therapy. But at month 6, 9, or 18, the psoriasis starts to come back. The dosing interval is inadequate, which is monthly with this drug. In other words, you might have to use an every 3 or 2 week interval to keep the patients responding, and even that fails over time. Speaking to something going on that lowers the effectiveness of the drug that wasn't present at the beginning of therapy. Now, what might that something going on be? It could be immunogenicity, but I just told you the studies don't show immunogenicity for this molecule. So what am I talking about? Well, for one, immunogenicity studies are wholly dependent on the assay used. If the assay is only slightly sensitive for the presence of relevant antibodies against drug, then it isn't depicting the whole picture. It's only describing some of the population that in reality is being victimized by anti-drug antibodies. But let's say, for the sake of argument, the paper is right. There are very few patients that have immunogenic problems. What else could account for loss of response for a drug that was primarily effective in the beginning of its therapy? Well, that might be that the target of the drug, in this instance IL-17A, but it could be any target, TNF, IL-12, IL-23, the target of the drug in some way either becomes less relevant to the disease pathophysiology, or compensatory mechanisms, biologic compensatory mechanisms, make it harder for the current drug level used for dosing to swamp out the current level of the target. The target blood levels or tissue levels go up, and therefore the dosing, the pharmacokinetics of the drug are now inadequate. So in many regards, the discussion about immunogenicity is not really, in my mind, fully relevant. The only thing I care about, and what anyone should care about, is whether a drug keeps working. And if it doesn't keep working, it doesn't really matter why it's not continuing to work. We need perhaps to either updose or change to another therapeutic. Or, as I often do, combine the drug with a molecule like methotrexate, which is known in clinical studies to reduce immunogenicity. So there are many strategies we can use, we can employ to maximize long-term efficacy and maintain drug levels at the level they need to be to clear psoriasis. It, in my mind, will always be the holy grail of psoriasis therapy to keep really strong responders as strong responders for very long periods of time.